we will focus on breast pathology. The first section is in the topic of papillary breast lesion. It is now my pleasure to introduce our speaker, Professor Tan Pui Hun, the plenary speaker for today. Professor Tan Pui Hun is the Senior Consultant Histopathologist and Chairman, Division of Pathology, Singapore General Hospital, and member of Editorial Board of the WHO Tumor Classification. Please join me to welcome our speaker, Professor Tan Pui Hun.
Thank you, Dr. Tikapon, and I'd like to thank Professor Sombun for involving me in this series and to take the opportunity to say hello to everyone and to wish everyone good health and to stay safe during this period. And looking forward to the times when we can travel to each other's countries so that we can interact in person. Thank you very much.
It is now time to start the first topic. Please join the topic.
Good afternoon. I'd like to first thank Professor Sombun and the Thai IEP Division for the kind invitation to participate in this Pathology Masterclass series. I will be delivering 2 talks on breast pathology, the first being papillary breast lesions. Papillary breast lesions can be defined as a group of neoplasms composed of papillary fronds covered by epithelial cells and invested by fibrovascular cores. The spectrum includes intraductal papilloma, which may demonstrate atypical ductal hyperplasia or ductal carcinoma in situ, papillary ductal carcinoma in situ, encapsulated papillary carcinoma, solid papillary carcinoma, and invasive papillary carcinoma. Then there are a few breast tumors which may have papillary architecture, and today I will be also addressing the adenomyoepithelioma and the recently described tall cell carcinoma with reversed polarity. During this presentation, I will walk you through the WHO 2019 updates of papillary breast lesions and discuss key pathological features, including recent molecular information. So let's start with the intraductal papilloma. The intraductal papilloma can be regarded as a benign papillary neoplasm characterized by finger-like fronds with fibrovascular cores lined by a layer of epithelial cells with accompanying myoepithelial cells. In terms of location within the breast, the intraductal papilloma can occur in the large central ducts in the retroareolar region, in which case it tends to be often solitary, or it can affect smaller peripheral ducts when they appear mostly to be multiple in nature, and we refer to them as either central or peripheral papillomas. The intraductal papilloma can occur in women over a wide age range, frequently presenting with non-bloody or bloody nipple discharge, or as a palpable mass if it has grown to a large size. Small intraductal papillomas, which are also sometimes referred to as microscopic papillomas or micropapillomas, may be an incidental microscopic finding. This is the gross appearance of an excised specimen of an intraductal papilloma, in which the lesion projects into a cystically dilated duct with its base attached to the wall over here, and you can observe some slightly fronded architecture with a solid grey-white appearance. Down the microscope at scanning magnification, the intraductal papilloma shows arborescent papillary fronds that extend into a distended duct space, and you can note the epithelial lining of the dilated duct and the papilloma, which is arising from the fibrous duct wall with fronded architecture and anastomosed papillary fronds. Myoepithelial cells are well preserved along the fibrovascular cores, separating the luminal epithelial cells from the fine fibrovascular stroma. And this is depicted here using immunohistochemistry for the myoepithelial markers P63 and CK14. Intraductal papillomas may be solidified by usual ductal hyperplasia, which is seen here as sheets of epithelial cells that efface the papillary architecture. The benign nature can be confirmed using immunohistochemistry for the high molecular weight keratin, CK14, which reveals a heterogeneous mosaic form of staining pattern within the epithelial cell population. Multiple papillomas of the peripheral ducts are thought to confer a greater risk of breast cancer compared to the solitary papilloma of large central ducts, and this is premised on observations in early studies of multiple papillomas that found a more frequent association with ductal carcinoma in situ or invasive carcinoma compared to the solitary papillomas. This study defined multiple papillomas as at least 5 papillomas in 2 non-consecutive tissue blocks, discovering that about 80% were associated with atypical ductal hyperplasia or atypical lobular hyperplasia and lobular carcinoma in situ, either within the papillomas or in the adjacent breast tissue, with 54% accompanied by DCIS or invasive carcinoma and bilateral disease in 24% of patients. It's important to note that multiple papillomas show a relative risk of breast cancer that is higher than proliferative fibrocystic lesions, but still lower than that of atypical ductal hyperplasia or atypical lobular hyperplasia. This work, published in 2006, reported solitary papillomas with ADH or ALH to be associated with a similar risk as ADH or ALH of the breast parenchyma, while multiple papillomas containing ADH or ALH possessed a higher risk than pure ADH or ALH of the adjacent breast. Nevertheless, there is no change to the management approach and no different action needed for the discovery of multiple papillomas that are benign in breast sections. High-risk surveillance is recommended for papillomas that contain atypical ductal hyperplasia and atypical lobular hyperplasia. How do we diagnose an intraductal papilloma containing atypical ductal hyperplasia or low-grade ductal carcinoma in situ? Well, when you encounter a low-grade atypical epithelial proliferation that measures less than 3 mm within an intraductal papilloma, we diagnose it as ADH within the intraductal papilloma. Whereas if one sees a similar abnormal proliferation that measures 3 mm or larger, we can regard it as low-grade ductal carcinoma in situ hosted within the intraductal papilloma. This 3 mm threshold was first set arbitrarily by Dr. David Page some years ago, and while there is limited scientific evidence for this size cutoff, it does provide a useful guide when interpreting low-grade atypical epithelial proliferations within intraductal papillomas. It's important to note that if the intraductal papilloma contains an abnormal epithelial population of intermediate to high-grade atypia, it is considered as having DCIS regardless of the size. Just to illustrate, an intraductal papilloma is seen here with the papillary fronted architecture in this field, and in this part of the papilloma, we encounter a solidified epithelial proliferation, which is atypical on closer scrutiny. And when we apply immunohistochemical stains, there is diminished reactivity of the epithelial population, which appears relatively monotonous for the high molecular weight keratin CK14, which only highlights areas of preserved myoepithelial cells, but the epithelial areas are generally negative for this marker, in contrast to usual ductal hyperplasia, whereby one expects to see a heterogeneous staining pattern for CK14 in usual ductal hyperplasia. On estrogen receptor immunostaining, the epithelial population in this area shows diffuse, consistent nuclear reactivity, supporting a clonal process, and if this area measures at least 3 millimeters or larger, one would render the diagnosis of a low-grade DCIS within an intraductal papilloma. How do we manage papillomas on core needle biopsy? It is generally agreed that any intraductal papilloma containing an atypical epithelial proliferation observed on core needle biopsy should be excised due to a greater risk of upgrade to malignancy. There is some uncertainty, however, as to how to approach papillomas without atypia seen on core needle biopsy. Earlier studies have reported higher upgrade rates on excision of these cases, raising concern that the lesions may be undertreated if excision is not performed. Many of these studies, however, had small sample sizes and potential selection bias, as pointed out in this review, in which 5 studies combining a total of 51 benign intraductal papillomas were considered, with upgrade to DCIS or invasive cancer in about 12% and upgrade to ADH or LCIS in about 14%. And it was suggested that based on these results, it may be prudent to excise all papillary lesions, even benign ones, until more data became available. Since then, there have been multiple studies that have reported upgrade rates of benign papillomas on core needle biopsy between 0 to 30%, noting that there has been variability in the studies of what is defined as upgrade on excision. Some studies have included papillomas with atypical ductal hyperplasia, and others encompassed those that were potentially radiologically discordant without any breast pathology review. And also there was no clarification of whether subsequent cancer was related to the papilloma on core needle biopsy, leading to artificial elevation of the upgrade rates. And after accounting for all these confounding factors, it was concluded that upgrade rates to either DCIS or invasive cancer for benign papillomas on core needle biopsy is very low, at 5% or less, and hence it is suggested that active surveillance of benign papillomas on core needle biopsy may be adequate. An alternative to open surgery is therapeutic excision via vacuum-assisted biopsy. In terms of molecular genetics, intraductal papillomas are clonal proliferations with reported loss of heterozygosity of 16p in both intraductal papillomas as well as those containing DCIS. Losses in 16q23 may be required for progression to malignancy, and it's been found that PIK3CA mutations in a third of intraductal papillomas and AKT1 mutations also in a third tend to be mutually exclusive. In comparison, papillary carcinomas show low rates of PIK3CA or AKT1 mutations, suggesting a different molecular progression pathway. Our next topic is on papillary ductal carcinoma in situ. Papillary DCIS is a subtype of ductal carcinoma in situ characterized by an intraductal papillary proliferation with arborizing fibrovascular cores lined by neoplastic epithelial cells, but mostly devoid of myoepithelial cells along the fibrovascular septa. Myoepithelial cells, however, are preserved at the periphery of the affected duct, like other forms of DCIS, and this finding distinguishes it from the encapsulated papillary carcinoma, in which myoepithelial cells are absent throughout the lesion. Papillary DCIS can occur in both central and peripheral ducts and can also coexist with other forms of DCIS or even with encapsulated papillary carcinoma. The neoplastic epithelial cells may also proliferate to form cribriform solid or micropapillary pattern of growth. There has been a description of a dimorphic morphologic pattern in which a second population of epithelial cells with ample clear cytoplasm is seen, in addition to the usual neoplastic epithelial cells that cover the papillae. And these clear cells have also been referred to as globoid cells, which may mimic myoepithelial cells but are not myoepithelial in nature. An illustration of papillary DCIS in which there are papillary structures covered by a uniform appearance of epithelial cells that distend this affected duct space. On immunohistochemistry, myoepithelial cells are preserved at the periphery of the affected duct, but appear to be absent throughout the papillary structures themselves. A closer scrutiny of P63 staining the myoepithelial cells at the edge of the affected duct, whereas along the fibrovascular fronts, there are no myoepithelial cells separating the neoplastic epithelial cells from the stroma. These are illustrations of papillary DCIS with a dimorphic pattern in which one can observe a second population of paler cells together with the columnar epithelial cells covering the papillary septa. Here, immunohistochemistry for CK14 displays the intact peripheral layer of myoepithelial cells, but are generally absent within the papillary structures themselves. And the pale cells are also negative for CK14, indicating that they are not myoepithelial in nature. The appearance of papillary DCIS differs from DCIS involving an intraductal papilloma. DCIS in an intraductal papilloma is diagnosed when there is morphologic evidence of a residual benign papilloma. In other words, we identify a benign papilloma which is partially effaced by conventional DCIS. The genetic abnormalities of papillary DCIS are similar to other forms of DCIS. The next papillary entity that I'll be talking about is the encapsulated papillary carcinoma. This was previously referred to as encysted or intracystic papillary carcinoma and is an expansile papillary neoplasm that is well circumscribed within a cystic space and surrounded by a fibrous wall or capsule. It is usually a single nodule, but multinodular cases have been described. Its key morphologic feature is the absence of myoepithelial cells both within as well as at the periphery of the neoplasm, distinguishing it from papillary DCIS, although both encapsulated papillary carcinoma as well as papillary DCIS may coexist. This tumor is most commonly diagnosed in the elderly postmenopausal woman and presents as a mass that is often centrally located and which may be associated with nipple discharge and pain. An illustration of an encapsulated papillary carcinoma with a coalesced papillary architecture, uniform epithelial population, circumscribed contour, and a fibrous wall. Closer scrutiny shows the epithelial population that is homogeneous, revealing areas of solidification as well as columnarity. Immunohistochemistry for the myoepithelial markers P63 and cytokeratin 5-6 disclose that there is a complete absence of myoepithelial cells within the fibrous septa as well as along the outer wall of the neoplasm. In encapsulated papillary carcinoma, the papillary fronds tend to be delicate or slender and lined by epithelial cells of low to at most intermediate nuclear grade. Mitotic activity is also low, with one study documenting a mean of 3 mitoses per 10 high power views. Areas of cribriforming can coexist, and solidification may also be observed. As mentioned earlier, myoepithelial cells are absent at the epithelial stroma interface along the papillae and at the tumor periphery, although focal staining for myoepithelial cells may sometimes be seen. The majority of these tumors strongly express ER and PR and are negative for HER2 on immunohistochemistry. There is a subset of tumors with resemblance to encapsulated papillary carcinoma that shows high-grade cytologic atypia. The frequency ranges from 2.5% to 14%, but the incidence is overall likely low, with one large study of 133 encapsulated papillary carcinomas revealing only 3% with high nuclear grade. And unlike classic encapsulated papillary carcinomas, these high-grade tumors are more likely to be ER negative and may show a triple negative phenotype with high mitotic activity and a greater frequency of associated invasive carcinoma. They also tend to be larger than encapsulated papillary carcinomas of low to intermediate nuclear grade. Death from disease has been reported in 1 out of 10 patients, and it is recommended to regard these high-grade tumors as invasive carcinomas for therapeutic considerations. So a wide excision specimen is seen here containing a circumscribed tumor which reveals large areas of hemorrhage and appears rather friable as well. On scanning magnification, there is a papillary architecture with geographic necrosis and hemorrhage and a circumscription in relation to the surrounding breast tissue. Higher magnification shows marked nuclear atypia with readily seen mitosis as well as necrosis. Immunohistochemistry with the myoepithelial marker smooth muscle myxin shows complete absence of myoepithelial cells within the tumor as well as at the interface with adjacent breast tissue. When an encapsulated papillary carcinoma is associated with invasion, it is only the invasive component that is sized and staged. In this setting, invasion is defined as tumor infiltrating beyond the fibrous capsule, and it is necessary to distinguish this from entrapped epithelial elements within the fibrous capsule or areas of sclerosis. The accompanying invasive disease can be either of no special type, cribriform, mucinous, or other types of invasive cancer, and receptor status may differ between the encapsulated papillary carcinoma and its accompanying invasive component. This is an illustration of an encapsulated papillary carcinoma with its thick fibrous wall, papillary architecture, and a large area of hemorrhage within the papillary tumor. Notice the presence of this area of invasive disease that extends beyond the contours of the encapsulated papillary carcinoma. And on closer scrutiny, it reveals appearances of an invasive carcinoma of no special type with anastomosed tubular structures in an irregular, haphazard fashion, extending into the fibrous stroma. There is ongoing debate about the encapsulated papillary carcinoma, whether it should be considered as an in situ or invasive disease. Proponents of an in situ nature report the very low prevalence of lymph node or distant metastasis in pure encapsulated papillary carcinoma without an invasive component, believing that the fibrous capsule limits invasion. Those who posit an invasive nature, albeit indolent in biological behavior, state the complete absence of myoepithelial cells and the few reports of metastasis to lymph nodes and distant sites quoted as 3% and 2.2% respectively. Yet a third school of thought regards it as sitting in a transitional phase between in situ and invasive disease, and there are reports of the expression pattern of matrix metalloproteinases that is intermediate between DCIS and invasive carcinoma. The current consensus by the WHO is to stage encapsulated papillary carcinoma as in situ disease, that is PTIS. Local regional recurrences reported at ranging from 4.9 to 7% occurs as either encapsulated papillary carcinoma, invasive papillary carcinoma, or invasive carcinoma of no special type. The next entity is solid papillary carcinoma. The solid papillary carcinoma is a neoplasm with a solid growth pattern with interspersed delicate fibrovascular cores resulting in a solid papillary architecture. One needs to specify whether it is the in situ or invasive form of the disease. Solid papillary carcinoma is most often multinodular, comprising clusters of ducts that are expanded by a solid papillary proliferation of epithelial cells. It is regarded as an uncommon tumor, estimated to constitute between 1 to 2% of primary breast cancers in an Asian population, and can occur across a wide age range with a mean and median age in the elderly postmenopausal woman. It usually presents as a mass which can be associated with bloody nipple discharge. This is the macroscopic appearance of the solid papillary carcinoma, which one can appreciate a slight multinodularity with a whitish to glistening cut surface and outlined over here, including areas of hemorrhage. At scanning magnification, it forms these solidified nodules of epithelial cells with a monotonous appearance that are punctuated by these congested fine fibrovascular cores accompanied by areas of fibrosis. Histologically, as shown earlier, they form expansile solid nodules with interspersed delicate fibrovascular cores that form the scaffold covered by a monotonous epithelial population. And these epithelial cells can reveal a spindled morphology and are of low to at most intermediate nuclear grade. High nuclear grade features are rare. Prominent spindling of these epithelial cells can resemble usual ductal type hyperplasia, but when interrogated using immunohistochemistry, they would stain negative for high molecular weight keratins, unlike usual ductal hyperplasia. Some cells may have a plasmacytoid or signet ring cell morphology and be accompanied by intracytoplasmic mucin, extracellular mucin, microcystic or microglandular areas. Clusters of foamy histiocytes and microcalcifications may also be observed. There can be epithelial cell palisading around the fibrovascular cores, forming rosette-like structures. Mitotic activity is usually low. So let's look at some illustrations. So this is a medium magnification of an expansile solid nodule that reveals these arborizing fine congested vessels, spindling of the epithelial cells with compressed elongated nuclei, presence of microcystic spaces, clusters of foamy histiocytes, pseudorosettes with the epithelial cells palisading around fibrovascular spaces. On immunohistochemistry, there is a diminished staining pattern for cytokeratin 5-6 with P63 highlighting some residual attenuated myoepithelial cells at the periphery of the solidified nodules. These tumors express neuroendocrine differentiation, and here is synaptophysin being expressed in the epithelial cells. Solid papillary carcinoma is considered an in situ disease when the nodules are rounded and well circumscribed with pushing contours. Myoepithelial cells may or may not be present at the periphery of these nodules. Myoepithelial cells are often absent within the nodules, but focal staining for myoepithelial cells, especially around the fibrovascular cores, has been reported. Invasive solid papillary carcinoma refers to tumors in which the solid nodules are devoid of a myoepithelial cell layer and also have irregular, jagged contours associated with a desmoplastic stroma. An example of solid papillary carcinoma in situ, in which the peripheral layer of myoepithelial cells is well highlighted using immunohistochemistry with cytokeratin 14. Here, solid papillary carcinoma shows a jagged architectural pattern with irregular nests that extend into a fibrous desmoplastic stroma, and this would be regarded as invasive solid papillary carcinoma on higher magnification, revealing the fibrovascular congested septa that accompanying these invading epithelial nests. Here is another example of a tumor in which there are both in situ components, as observed here with the rounded contours, and an invasive element where irregular tumor islands extend into fibroadipose tissue. Here is a solid papillary carcinoma with its accompanying immunohistochemical image, revealing in situ disease in this corner with the corresponding positivity for cytokeratin 14 myoepithelial cells, whereas the invasive component here is devoid of any accompanying peripheral myoepithelial cells. Solid papillary carcinoma in situ can also be accompanied by invasive disease of no special type, mucinous, tubular, lobular, or even mixed subtypes. Conventional ductal carcinoma in situ and benign intraductal papillomas can be seen in the vicinity of solid papillary carcinoma in situ, including cases in which the solid papillary carcinoma is observed growing into an adjacent benign papilloma. Solid papillary carcinomas are usually ER positive, HER2 negative, with frequent neuroendocrine differentiation as observed earlier. The invasive carcinoma component can also demonstrate neuroendocrine differentiation. So here is a mucinous carcinoma that accompanies a solid papillary carcinoma with extracellular lakes of mucin in which the invading tumor nests are suspended. In terms of biological behavior, solid papillary carcinoma in situ has not been found to metastasize to regional lymph nodes or distant sites, even in cases where myoepithelial cells are completely absent at the periphery, provided the tumor nodules show well circumscribed pushing borders without any features of invasive solid papillary carcinoma. And those tumors with lymph node or distant metastasis are either invasive solid papillary carcinomas or solid papillary carcinoma with an accompanying invasive component. Local recurrences can be found in both in situ solid papillary carcinoma or those with invasive disease, but the incidence is generally low. And overall, there is a low-grade behavior with few deaths, and the deaths occurring in solid papillary carcinomas with invasive disease. The molecular genetics of the encapsulated papillary carcinoma revolve around loss of heterozygosity at chromosomes 16, 17, and 18. HER2 amplification and p53 mutations are absent or rare. There are reports of structural abnormalities at chromosome 1, including fusion with chromosome 16 observed on fish. Among papillary carcinomas that encompass the encapsulated papillary carcinoma, solid papillary carcinoma, and invasive papillary carcinomas, there is a similar pattern, although fewer gene copy number alterations in chromosome 16 as compared with low-grade ER-positive invasive ductal carcinoma of no special type. PIK3CA mutations occur in 43% of cases, not significantly different from grade and ER-matched invasive ductal carcinomas. Although papillary carcinomas are genomically similar to invasive ductal carcinoma of no special type, there are some differences at the transcriptomic level, with a lower level of expression of genes related to cellular growth, proliferation, cell assembly and organization, cell adhesion and movement and migration in papillary carcinomas. And this may explain the indolent behavior, limited invasiveness, and generally favorable prognosis of papillary carcinomas when compared to grade and ER-matched invasive ductal carcinomas of no special type. Invasive papillary carcinoma refers to an invasive carcinoma with more than 90% papillary architecture. Much of the published literature describing these cases are actually variants of encapsulated or solid papillary carcinoma with invasion, and hence, when we drill down into the literature, there is not much clinical pathological data on this rare tumor entity. In accordance with its invasive nature, myoepithelial cells are absent throughout the tumor. Metastasis to the breast, such as ovarian serous carcinoma, lung adenocarcinoma with papillary pattern, as well as thyroid papillary carcinoma, should be excluded when one encounters an invasive papillary carcinoma in the breast. And immunohistochemical workup with these markers, together with the relevant clinical history, should be able to provide a definitive diagnosis. Illustrations of invasive papillary carcinoma in this example, tumor nests that recapitulate papillary architecture are seen invading into a fibrous desmoplastic stroma. Another example whereby the tumor shows embedded papillary structures associated with areas of necrosis. Tumors with a papillary architecture include the adenomyoepithelioma, which is a biphasic neoplasm composed of a proliferation of both inner luminal epithelial cells as well as outer myoepithelial cells. There can be a variety of architectural patterns in adenomyoepithelioma, including tubular, spindle cell, lobulated, and papillary. And when a papillary architecture predominates, it can be difficult to differentiate it from intraductal papilloma with prominent myoepithelial cells. Adenomyoepithelioma with intraductal growth, merging with intraductal papillomas, have also been described. Myoepithelial cells in the adenomyoepithelioma are usually more conspicuous, numerous, and larger than those seen in intraductal papillomas, although it is recognized that there may be significant morphologic overlap. A low-power illustration of an adenomyoepithelioma with a fibrous wall and a lobulated architecture, and even at this magnification, you can see these darker epithelial elements accompanied by paler cell populations representing the myoepithelial component. Closer scrutiny shows the tubules lined by luminal epithelial cells and rimmed by paler myoepithelial cells, which appear prominent and giving a balanced biphasic appearance. Adenomyoepitheliomas may demonstrate paradoxical staining of high molecular weight keratins for the luminal cells instead of the myoepithelial cells. ER expression can be either positive or negative. ER-positive adenomyopatheliomas have been found to harbor PIK3CA or AKT1 mutations similar to papillomas, whereas ER-negative adenomyopatheliomas have recurrent HRAS mutations in addition to PIK3CA or PIK3R1 mutations. RAS immunohistochemical staining decorates about 71% of HRAS mutant adenomyopatheliomas with 100% specificity, suggesting a potential utility of this immunohistochemical stain in the diagnostic workup of adenomyopatheliomas. There is a form of adenomyopathelioma which is malignant, and this refers to an adenomyopathelioma in which either the luminal epithelial component, the myoepithelial component, or both show malignant features. So here is an adenomyopathelioma in which both luminal epithelial and myoepithelial cells are seen, forming anastomosed tubules, accompanied by areas of necrosis and hemorrhage. On closer scrutiny, the myoepithelial cells show some degree of nucleatypia with vesicularity of the nuclei. This case would be regarded as a malignant adenomyopathelioma, and I just want to draw your attention to this recent publication on a proposal for classifying breast adenomyopatheliomas in which the malignant adenomyopatheliomas can be categorized into 3 different variants, and the case that I've just illustrated would be a malignant adenomyopathelioma in this group of adenomyopathelioma with invasive carcinoma. Finally, I'll just talk about tall cell carcinoma with reversed polarity, which used to be referred to under previous terminologies of solid papillary carcinoma with reverse polarity and breast papillary tumor resembling the tall cell variant of thyroid papillary carcinoma. At the WHO Consensus Conference, it was decided that the term to describe this tumor would be best labeled as tall cell carcinoma with reversed polarity, acknowledging the previous terminologies used. This tumor is regarded as invasive and comprises variably circumscribed solid nests of cells with central slender fibrovascular cores resulting in a solid papillary pattern, although true papillae follicular structures resembling those of the thyroid as well as somamatous calcifications can also be observed, underscoring that resemblance to papillary thyroid carcinomas. Foamy macrophages are often present within the fibrovascular cores, and the tumor cells are usually tall columnar in shape, featuring abundant eosinophilic cytoplasm, unlike those seen in solid papillary carcinoma of the breast. The nuclei of these cells also display nuclear grooves, occasional intranuclear inclusions, and the unique morphologic feature is that they are polarized away from the base of these cells, giving rise to the appearance of reversed polarity. An example of tall cell carcinoma with reversed polarity showing the congested fine vessels and the cells with eosinophilic cytoplasm with the nuclei that seem to float up from the bases of the cells and having a regimented pattern along the apical borders of the cells. Another example with papillary architecture, and again the nuclei approximating the luminal borders of the cells. These tumors have a triple negative phenotype with only a minority of cases staining for hormonal receptors. There's positive reactivity for both high and low molecular weight cytokeratins as well as calretinin. And unlike the solid papillary carcinoma of the breast, these do not display neuroendocrine differentiation and are negative for synaptophysin and chromogranin. And also, unlike thyroid carcinomas, they are negative for TTF1 and thyroglobulin, staining variably for the breast markers GATA3, GCDFP15, and mammoglobin. Molecular studies have found recurrent IDH2 mutations with concurrent PIK3CA or PIK3R1 abnormalities. An immunohistochemical antibody for the IDH2 protein stains the mutant tumors in more than 90% of cases and may thus be a cheaper alternative to IDH2 sequencing in the diagnostic workup of these tumors. Finally, I'll leave you with some tables comparing the various papillary breast neoplasms. So the intraductal papilloma with florid usual ductal hyperplasia versus one with low-grade ductal neoplasia. These are the key differences. Myoepithelial cells being diminished in areas of ADH and DCIS with a monotonous epithelial population of low nuclear grade. Surrounding breast tissue may display ADH or DCIS, and on immunohistochemistry, there would be diminished staining for P63 in these abnormal areas. Similarly, for the high molecular weight keratins, whereas for ER, there would be diffuse positivity in the ADH or low nuclear grade DCIS foci within the intraductal papilloma. Epithelial displacement can be a particular diagnostic problem in evaluating whether there is an invasive carcinoma associated with a papillary tumor. There should be a history of prior instrumentation and reactive changes accompanying the displaced epithelial cells with hemorrhage, hemosiderin, granulation, inflammation, and fibrosis. The epithelial nests that are displaced are usually confined within the fibrous tract, and immunohistochemistry may reveal preservation of the myoepithelial cells, but they can also be negative, so this may not always be helpful. For encapsulated papillary carcinoma and papillary DCIS, the key feature is the presence of myoepithelial cells along the affected duct wall in papillary DCIS, as opposed to their complete absence in encapsulated papillary carcinoma. Both lesions can coexist. When comparing the solid papillary carcinoma with the encapsulated papillary carcinoma, these are the key differences. The solid papillary carcinoma is observed as multinodular solidified expansile masses, whereas the encapsulated papillary carcinoma tends to be a single circumscribed tumor. Myoepithelial cells can be observed at the periphery of the nodules of the solid papillary carcinoma, whereas they are absent in the encapsulated papillary carcinoma. Mucin can be observed in solid papillary carcinoma, tending to be absent in encapsulated papillary carcinoma, and neuroendocrine differentiation is often observed in the solid papillary carcinoma, whereas it's absent in encapsulated papillary carcinoma. In conclusion, I've talked about breast papillary neoplasms and their distinct pathological features that can allow classification into discrete entities in most cases. However, several morphological similarities may exist on a continuous spectrum, ranging from benign to invasive tumors, especially exemplified by encapsulated papillary carcinoma that seems to be a tumor in transition from an in situ to invasive disease. Tumors with overlapping features require careful morphologic examination and use of adjunctive immunohistochemistry in order to best categorize them. And there may be cases that defy classification, which can represent new entities that have not yet been fully described, warranting further study. For instance, the recently acknowledged tall cell carcinoma with reversed polarity. Newer technologies in the field of molecular genetics may yield further insights that can help improve our diagnosis and prognostication of these tumors. And much of what I've talked about can be obtained in these references with a recent review article that's just being published in Modern Pathology. Thank you very much for your kind attention.
Thank you. And now we have some questions from the Facebook Live. May I ask Professor. The first question is, how would you state a high-grade encapsulated papillary carcinoma of breast?
Thank you for the question. For high-grade encapsulated papillary carcinoma, it is recommended that they be staged as invasive disease. So I must say that these tumors are extremely rare, and the experience with their behavior is still relatively limited. But the few cases that have been described have shown a more aggressive behavior similar to invasive disease. So if you have an encapsulated tumor that has got high nuclear grade features, and say it measures more than 2 centimeters, then you would regard it as akin to an invasive carcinoma that measures more than 2 centimeters. So, you know, T2 disease.
Okay, thank you, Professor. And another question is there any relationship between is there any relationship between adenomyoepithelioma of breast and epithelial myoepithelial carcinoma of salivary gland?
Yeah, so that's another great question. The adenomyoepithelioma of the breast resembles the epithelial myoepithelial carcinoma of the salivary gland. And during the discussion before the WHO publication, there was some debate about terminology and whether or not breast adenomyoepitheliomas should follow the terminology used in the salivary gland, whereby, you know, it is considered an epithelial myoepithelial carcinoma. But in the breast, many of the adenomyoepitheliomas that have been diagnosed actually follow a rather benign outcome. And they are regarded in most instances as tumors with very low grade or indolent behavior. So, you know, using the term carcinoma might not be appropriate. However, we recognize that adenomyoepitheliomas of the breast can show cytologic atypia, and they may appear similar to the epithelial myoepithelial carcinoma of the salivary gland when both the epithelial as well as the myoepithelial components display cytologic atypia. And that's when we classify them as malignant adenomyoepitheliomas. So while there is a resemblance in the breast, we use the terminology that most pathologists are familiar with and evaluate the components carefully to describe whether or not there is sufficient atypia to consider it as a malignant form of the adenomyoepithelioma.
Okay, and we have another question. Should immunohistochemical study be ordered in the order to confirm the neoplastic origin in breast biopsy showing invasive papillary feature in a patient who has only the history of breast mass?
So if we see an invasive papillary carcinoma on a breast core biopsy, certainly we need to work it up and get an appropriate clinical history. But we know from experience also that sometimes clinical history is not available of any prior tumor elsewhere. And sometimes the metastasis to the breast can be the first presentation. So yes, I would say that if one sees an invasive carcinoma with papillary features on a breast core biopsy, it is generally recommended that we work it up to exclude possibilities of this tumor being metastasis from sites like the lung, the ovary, or the thyroid. The presence of breast primary markers such as GATA3 and GCDF-P15 and mammoglobin can help to define a breast origin. Similarly, we can see in situ disease that can also help to steer the diagnosis towards a primary breast origin. But because invasive papillary carcinoma of the breast is extremely rare, it is necessary to rule out the possibilities of metastasis.
Okay, we also have some about 3 or 5 questions, but I have time for only one question, I think. And the last question I will pick up is, have you encountered mixed tumor composing a mixture of solid papillary carcinoma and encapsulated papillary carcinoma with invasive component? How you report this lesion?
I think that's a great question too. In the descriptions that you see in the text, we always describe single tumor entities, but in reality, we do see admixtures of different tumor types. So as mentioned, encapsulated papillary carcinoma can coexist with papillary DCIS. I've also seen situations in which tumors with solid papillary carcinoma can coexist also with encapsulated papillary carcinoma. So my practice is to evaluate the morphology and to describe based on the morphology. So if I have a tumor that includes both solid papillary areas, encapsulated papillary carcinoma areas, I would then, mention in my report that this particular tumor mass in the patient has inclusive of all these different components. So yes, mixed components can occur, and just, sort of like document them in the report.
Okay, thank you, Professor. And the rest of the question will be posted on the Facebook after the second session finish. And then I think it's time to start the next topic. The next topic will be about fibroepithelial breast lesion. Please enjoy the topic.
This is the second lecture in this breast pathology masterclass series, and the topic is on breast fibroepithelial tumors. So why talk about fibroepithelial tumors of the breast? Well, they represent a group of biphasic neoplasms comprising fibroadenomas and phyllodes tumors, which pose diagnostic challenges from their overlapping histological characteristics in core biopsy interpretation, how grading of phyllodes tumors is done, and the impact on prognostication. There is also emerging data on how to approach surgical margins for breast phyllodes tumors, as well as information on their molecular genetics. So for today's talk, I will walk you through the pathology of these neoplasms, discuss diagnostic challenges, including an approach to core biopsy interpretation, highlight recent updates, in summary, to provide a practical approach to the interpretation of fibroepithelial lesions in diagnostic practice. Much of what I will be saying can be found in the latest volume of the WHO Blue Book on Breast Tumors, and the fibroepithelial tumors are discussed in Chapter 3, which include the hamartoma as well, although for today's talk, I will not be focusing on the hamartoma. As mentioned earlier, these are biphasic neoplasms and are comprised of a proliferation of both epithelial and stromal components. And the fibroadenoma and the phyllodes tumor are the main entities in this group of lesions. For the fibroadenoma, we'll revise key pathological features, delve into the diagnostic challenges when they present in young patients, and on core biopsy. For the phyllodes tumors, a discussion of key pathological features will also ensue, together with the grading criteria and WHO 2019 updates. specific diagnostic challenges such as the distinction of the benign phyllodes tumor from a cellular fibroadenoma, as well as at the malignant end of the spectrum, the malignant phyllodes tumor from a metaplastic breast carcinoma or breast sarcoma will be discussed. And we'll also touch on the surgical margins and molecular genetics of these tumors. These are the several phases of the gross anatomy of the fibroadenoma, from those with bosselated outlines, myxoid cut surfaces, a fibrous homogeneous appearance, those with lobulations. They can also undergo ossification and have a grittiness to the cut and feel, and some fibroadenomas may assume large sizes, which we term giant fibroadenomas when they exceed more than 5 centimeters in dimension. Down the microscope, it shows a circumscribed and pushing border. Infarction may occur, especially in pregnant or lactating patients. The stroma tends to be of low cellularity, but may show myxoid or hyalinized appearances with stromal multinucleated giant cells that can also be sometimes encountered. Calcifications, ossifications, pseudoangiomatous stromal hyperplasia may be observed. The epithelium shows an arrangement with the stroma that can be described as pericanalicula or intracanalicula. There can be usual ductal hyperplasia, apocrine metaplasia, sclerosing adenosis, and the entire spectrum of atypical epithelial proliferation to in situ and invasive cancer can occur within the fibroadenoma. This is a typical microscopic appearance of a fibroadenoma with both epithelial and stromal components arranged in an intracanalicular pattern in this portion, whereby the stroma grows against the epithelium and compresses the epithelium into these arc-like forms. And there can be pericanalicular growth pattern as well, like in this area, where the stroma grows around patent epithelial tubules. These growth patterns do not have any clinical significance, apart from the more frequent correlation of the intracanalicular pattern with the presence of MET12 mutations. An illustration of a fibroadenoma with areas of hemorrhagic infarction that can be seen over here. Note the well-defined and circumscribed boundary. Stromal multinucleated cells, as depicted here, can be seen. Pseudoangiomatous stromal hyperplasia within a fibroadenoma, represented by these slit-like spaces. A fibroadenoma with sclerosing adenosis on core biopsy, which may mimic an invasive process. Ductal carcinoma in situ of cribriform pattern within the confines of a fibroadenoma. Lobular neoplasia can also be observed in the body of the fibroadenoma, as represented by these rounded uniform cells with discohesion occupying the epithelial compartment. A fibroadenoma with invasive lobular carcinoma, seen as strands of pearl-like cells within the stroma, accompanied by lobular neoplasia as well. Fibroadenoma variants include the cellular form, which shows a cellular stroma and may resemble the benign phyllodes tumor, the complex fibroadenoma, in which at least one of the following features is present: sclerosing adenosis, papillary apocrine metaplasia, cysts 3 mm or larger in size, epithelial calcifications. There's the juvenile fibroadenoma, which generally displays a pericanalicular growth pattern with increased stromal cellularity and gynecomastoid type of usual ductal hyperplasia. The myxoid fibroadenoma is typified by the presence of myxoid stroma and may be occasionally associated with the Carney syndrome. A cellular fibroadenoma typified by the dense aggregation of the stromal cells. A recent study published on the genetic differences between benign phyllodes tumors and fibroadenomas using targeted next-generation sequencing, found that there were no significant differences detected between conventional fibroadenomas and cellular fibroadenomas, supporting their categorization together as fibroadenomas. TERT promoter alterations were most optimal in discriminating between fibroadenomas and benign phylloides tumors. An illustration of a complex fibroadenoma with the presence of sclerosing adenosis, papillary apocrine metaplasia, cysts 3 mm or larger in size, and epithelial calcifications. The juvenile fibroadenoma, seen at scanning magnification, with rounded contours and a cellular spindled stroma with usual ductal hyperplasia, featuring these micropapillary tufts, giving a gynecomastoid type of an appearance. The myxoid fibroadenoma with the slightly watery myxoid stroma. What about fibroadenomas in the young? These are two key papers that have evaluated this group of tumors with 34 fibroadenomas from the Memorial Sloan Kettering Cancer Center study and 62 fibroadenomas from our own group. Key findings were that mitotic activity in fibroadenomas of young females 18 years or less in age can be substantial and range up to 6 per 10 high power fields. And except for mitotic activity, usual fibroadenomas, benign and malignant phylloides tumors are morphologically indistinguishable from the adult counterparts. The juvenile fibroadenoma is the commonest form of fibroepithelial lesion and may display slight stromal expansion, intratumoral heterogeneity without stromal atypia. And it's important that one is aware of these morphologic features to avoid overdiagnosis of phylloides tumors, which may lead to additional unnecessary and potentially disfiguring surgery. And in our own study, we found that leaf-like fronds and increased stromal cellularity may be encountered in pediatric fibroadenomas. Nevertheless, both studies agreed that these tumors show a benign prognosis without any predisposition to phylloides tumor or cancer development. So this is a fibroadenoma from our own cohort with leaf-like fronds. However, there is no significant accompanying stromal hypercellularity. What about the genomics of these tumors? Well, it's reassuring that there have been no TERT promoter or cancer driver mutations discovered in these lesions. And just as an aside, the TERT is a gene that encodes for the catalytic domain of the human telomerase reverse transcriptase, playing a major role in cellular senescence and immortality. And the expression of telomerase is a hallmark of cancer, so it's reassuring that these pediatric fibroepithelial lesions do not disclose any abnormalities in this gene. Moving now to the core biopsy of fibroepithelial tumors. Core biopsies, as we know, represent the standard of care in preoperative diagnosis of breast lesions discovered clinico-radiologically. No further treatment is needed for a diagnosis of fibroadenoma on core biopsy versus the need for considering excision biopsy when the conclusion of phylloides tumor is made. So there have been some questions that are posed. They include, is the diagnosis of an unambiguous fibroadenoma on core biopsy reliable? Do we need to be concerned about underdiagnosing a phylloides tumor? And for cellular fibroepithelial lesions, are there pathological features that can predict which will turn out to be a phylloides tumor on subsequent excision? So this is a study from 3 centers which was presented some years ago at the USCAP, and it looked at the frequency and characteristics of phylloides tumor subsequent to a diagnosis of fibroadenoma on breast core needle biopsy, and the incidence was extremely low, 0.38%. Most of these phyllodes tumors were categorized as benign, and it is believed that the heterogeneity of these tumors with fibroadenoma-like areas contributed to the core needle biopsy excision discrepancies. However, no pathologic features on core needle biopsy appeared to be prospectively predictive of phyllodes tumors at excision. Suspicious imaging findings at the time of core needle biopsy or on follow-up should prompt consideration for surgical excision. The conclusion was that the diagnosis of an unambiguous or a conventional fibroadenoma on core needle biopsy is reliable and safe when there has been adequate imaging correlation and follow-up. Moving up a notch to cellular fibroepithelial lesions, are there predictors of phyllodes tumor on core biopsy? These are some studies that have attempted to answer this question, and key findings reported include stromal hypercellularity, mitotic activity, stromal overgrowth, fragmentation of the tissue, adipose within stroma, ill-defined lesional borders, morphologic heterogeneity, subepithelial condensation, nuclear pleomorphism, and an age of 40 years and above. Immunohistochemistry for proliferation markers like Ki67 and topoisomerase 2 alpha is also thought to be potentially helpful, as well as a reduction in CD34 staining, although these immunohistochemical stains are unable to be useful in routine practice. Some illustrations of core biopsy features that can be predictive of phyllodes tumors. Stromal hypercellularity here with the stromal nuclei touching and overlapping. Mitotic activity. Ill-defined lesional borders with adjacent breast tissue. Presence of adipocytes within the lesion. A more florid example of adipose infiltration by the neoplastic stromal cells, fragmentation of the core biopsy material with these almost rounded blobs of tissue. Can molecular pathology help? Well, this is a study using a 5-gene reverse transcription PCR assay that was able to accurately classify about 93% of the core biopsy samples into fibroadenomas or phyllodes tumors. Another study using a 16-gene panel building a multivariate logistic regression model that developed a predictive scoring system with the ability to classify a fibroepithelial lesion on core biopsy into a low or high risk of being a phyllodes tumor. We have also looked at artificial intelligence modeling to predict whether a core biopsy sample of a fibroepithelial lesion is more likely to be a fibroadenoma or phyllodes tumor, and this paper has just been submitted for consideration for publication. Moving now to breast phyllodes tumors, which can be defined as fibroepithelial neoplasms showing prominent intracanaliclar architectural patterns, leaf-like stromal fronds, capped by luminal epithelial and myoepithelial layers and accompanied by stromal hypercellularity. Some gross appearances of the phyllodes tumor, which may show a whitish walled surface, myxoid consistency, presence of cystic degeneration, a fleshy lobulated appearance, and fronded architecture as in this tumor. The prototypical histologic appearance of a phyllodes tumor is what we sometimes term the phylloidal frond, which is composed of a broad expanse of hypercellular stroma, which is surmounted by bilayered luminal and myoepithelial cells. The breast phyllodes tumor comprises between 0.3% to 1% of all breast tumors and 2.5% of all fibroepithelial tumors, affecting the more mature woman in the 5th decade or older. There are reports of higher incidence in Asian women in whom they can occur at younger age. Clinically, they present as firm to hard breast masses, which may stretch and ulcerate the overlying skin. And unfortunately, clinical radiological features are unable to accurately and consistently distinguish the fibroadenoma from the phylloides tumor. The phylloides tumor is divided into benign, borderline, and malignant grades based on a constellation of histological features that include the nature of the tumor border, the degree of stromal hypercellularity and atypia, mitotic activity, and the presence or otherwise of stromal overgrowth. So this is a table that is taken from the latest volume of the WHO tumor classification, which lists the different histological parameters that separate the benign from borderline and malignant phylloides tumors. So for the benign phylloides tumor, the tumor borders are well defined. Stromal cellularity is usually mild. There is mild or no stromal atypia. Mitotic activity is low, less than 5 per 10 high power fields, and there is no stromal overgrowth and no malignant heterologous elements. The borderline phylloides tumor may display a well-defined tumor border but can also be focally permeative. The stromal cellularity is usually moderate. There is mild to moderate stromal atypia, and stromal mitosis range from 5 to 9 per 10 high power fields. Stromal overgrowth is usually absent, or if present, tends to be very focal. And again, there are no malignant heterologous elements. The malignant phylloides tumor shows permeative borders, usually marked and diffuse stromal cellularity with marked stromal atypia. Mitotic activity in the stromal component is usually abundant, 10 or more per 10 high power fields. Stromal overgrowth is often present, and malignant heterologous elements may be seen, with the exception of liposarcoma that can independently indicate malignancy in the absence of the other histological characteristics of malignancy. The benign phylloides tumor constitutes between 60 to 70% of all phylloides neoplasms. There can be periepithelial or subepithelial stromal condensation with elongated, branching cleft-like ducts. Like the fibroadenoma, stromal multinucleation, myxoid change, and hyalinization can be observed. An illustration of a benign phylloides tumor with well-developed stromal fronts, mild hypercellularity, and a distinct border with the adjacent breast tissue. Periepithelial stromal condensation seen as these aggregates of stromal cells that hug the epithelium. Elongated, clefted ducts, which often give way to more typical areas of a phylloides tumor. At the other end of the spectrum is the malignant phylloides tumor, which comprises between 8 to 20% of all phylloides neoplasms. Stromal overgrowth may be present and is defined as the absence of epithelial elements in one low power field using the ×4 microscope objective and the ×10 eyepiece, corresponding to an overall ×40 magnification. An example of the malignant phylloides tumor in which there is an expanse of hypercellular stroma forming a frond projecting into a clefted space, and areas where there is diffuse infiltration into the surrounding adipose tissue, absence of epithelial elements indicating stromal overgrowth. Liposarcoma was previously considered a malignant heterologous element that could independently indicate malignancy in a phyllodes tumor even in the absence of other histological parameters of malignancy. The latest volume of the WHO, however, had a consensus that liposarcoma in the breast has no metastatic potential and hence is insufficient as a sole criterion to warrant malignant grade. This stance is supported by the finding that abnormal adipocytes in these tumors lacked MDM2 or CDK4 amplifications in contrast to extramammary well-differentiated liposarcoma, and hence there's a need to evaluate other stromal parameters for grading purposes. So an example of liposarcoma with lipoblasts and peripherally compressed hyperchromatic nuclei as well as scalloping of the nuclear contours. In between the benign and malignant grades is the borderline phyllodes tumor, which comprises between 15% to 26% of all these neoplasms. An illustration shows hypercellular stroma, relatively well-defined contours at low magnification. However, on closer scrutiny, one observes that there is infiltration and entrapment of the surrounding adipose tissue, giving a slightly irregular tumor border. So why do we have to grade breast phyllodes tumors? Well, we know that grade correlates with clinical behavior in terms of local recurrences. Metastases occur in malignant and very rarely the borderline tumors. In terms of the recurrence rates, these are figures from a study that we did some time ago. Benign tumors recur between 10 to 17% of cases, borderline tumors 14 to 25%, and malignant tumors up to 30%. In comparison, metastatic rates are listed here. Almost 17% for malignant tumors, 1.6% for borderline, and 0.1% for benign tumors. There have been anecdotal case reports of benign phyllodes tumors metastasizing, but I suspect that these cases may not have been altogether completely well sampled or histologically evaluated. When metastases occur, they usually comprise malignant stromal or heterologous elements devoid of epithelium. When considered as an overall group, metastases are rare, occurring in up to 2% of all tumors and almost exclusively in the malignant grade. Are there predictors of metastasis? This study showed that age of more than 50 years, stromal overgrowth, diffuse marked atypia, necrosis, and mitosis of 10 or more per 10 high power fields were able to correlate with the likelihood of metastatic behavior. And our own study found large tumors, more than 9 centimeters in size, together with the presence of heterologous elements, were associated with more frequent metastasis. Illustrations of metastatic phyllodes tumor, this to the lung, with malignant spindle cells effacing the underlying alveolar lung spaces, metastasis to a lymph node with geographic necrosis and high-grade malignant spindle cells, metastasis to the stomach with the malignant spindle cells obscuring the glandular architecture. What are some grading pitfalls? Well, phyllodes tumors are known to be morphologically heterogeneous, so it's important that there is adequate sampling of at least 1 block per centimeter of maximum tumor dimension, with additional sampling of grossly heterogeneous areas. Core biopsy changes in the excision specimen should not be mistaken for permeative tumor borders used in grading, and stromal multinucleated giant cells ought not to be equated with stromal atypia. A histological picture of a core biopsy site in an excision specimen of a phyllodes tumor, and on cursory overview, one might mistake this for the permeative border of a phyllodes neoplasm and then upgrade it to a borderline category. So what are some clues to this appearance being that of the reparative change of a core biopsy? Well, they include the presence of granulation, inflammation, hemosiderin, and fat necrosis. An example of a tumor showing multinucleated stromal giant cells with degenerative nucleotipia, and these should not be interpreted as marked stromal atypia. And it's important, therefore, that one evaluates the non-multinucleated stromal cells in order to determine the final grading of the tumor. Fundamental issues with current grading and classification approaches for phyllodes tumor are that the grade assignment is inherently imperfect when one has to rely on multiple parameters for evaluation, with each parameter having its own tiers of categorization. So let's look at how phyllodes tumors are graded in usual practice. So we look at the tumor border, but both the benign and borderline tumors may demonstrate circumscribed contours, whereas either the borderline or malignant tumor can display permeative margins. With regard to stromal cellularity, mild increase can be seen in either the benign or borderline tumors. And for atypia, a similar situation occurs in which mild atypia can be observed in either the benign or borderline grade. And while mitotic ranges are given for the different grades, they do not always fall precisely into these ranges. Stromal overgrowth is absent in benign and often borderline tumors as well, whereas its presence can be seen in either the borderline or malignant tumor. And the malignant heterologous elements are absent in both benign and borderline grades, and its rare presence in the malignant tumors makes it not very helpful on a regular basis. So essentially, we are trying to dichotomously grade borderline, benign, and malignant tumors using multiple parameters that are very complex, and this is because there are many overlapping characteristics in the three different tumor grades which actually exist on a continuum. So are there ways to overcome this difficulty? Well, we looked at developing a nomogram based on stromal atypia, mitosis, overgrowth, and surgical margins, called the Amos criteria, that are able to weight the importance of the different histological characteristics. And there is a site in which you can access to crunch out a nomogram score that will allow you to predict the likelihood of recurrence in an individual patient with phyllodes tumor. So let's look at an illustration. If a tumor shows moderate stromal atypia with 6 mitosis per 10 hypophils, presence of stromal overgrowth, and positive surgical margins, the nomogram score of 67 will be able to calculate for you the recurrence-free probabilities at 1, 3, 5, and 10 years. Has this nomogram been validated? Well, it's been studied in different populations. In this Japanese group, where the concordance index was close to 1, similarly in a small Australian cohort, and in a larger study of 259 women, where the concordance index was 0.86. This is an abstract from 2017 USCAP, which also found that it was useful in a US-based cohort of women with phyllodes tumors, yielding a concordance index of 0.84. And more recently, a Korean study found a concordance index of 0.62 and concluded that it was helpful in predicting outcomes in Korean women with phyllodes tumors. Limitations of the nomogram are the following. It does not distinguish between local and distant recurrences. There are inter-observer reproducibility issues in assessing the Amos criteria. It is based on excision specimens and would still require validation in larger cohorts with more events. Emerging and novel biological data have not been integrated into this nomogram. Moving now to differential diagnosis. The cellular fibroadenoma resembles a benign phyllodes tumor but differs from it in the absence of an exaggerated intracanalicular growth pattern and lack of stromal fronds. Fibromatosis may resemble stroma-dominant, benign or borderline phyllodes tumor but lacks an epithelial component or stromal fronds. Immunohistochemistry is CD34 negative in fibromatosis, where it's usually positive in phyllodes tumors. Beta-catenin also can be helpful, although this is not always reliable. The periductal stromal tumor is now classified as a subtype of phyllodes tumor and therefore, in terms of differential diagnosis, may not be so critical. Morphologically, it shows periductal stromal hypercellularity without the typical phylloidal stromal fronds. Metaplastic carcinoma of spindle type resembles the borderline or malignant phyllodes tumor but will not possess stromal fronds, and the presence of any admixed in situ or invasive carcinoma will relegate the tumor to a metaplastic carcinoma category. On immunohistochemistry, epithelial markers will be positive in a metaplastic carcinoma. The sarcoma resembles malignant phyllodes tumor with stromal overgrowth. However, the distinction may not be so crucial because biological behavior of primary breast sarcoma appears to be similar to that of malignant phyllodes tumors, and in fact, some of them could be underlying phyllodes tumors that have overrun any residual phylloidal features. Unusual tumors like the melanoma can resemble the stromal component of malignant phyllodes tumors, but immunohistochemistry will be able to make that distinction. A word of caution in using keratins to differentiate between phyllodes tumor, sarcoma, and metaplastic carcinoma. This is a study done almost 10 years ago in which we found variable expression of epithelial markers in the stroma of phyllodes tumors, although the staining tended to be very focal, involving less than 5% of the stromal cells and in a patchy distribution. So an illustration from the paper of a malignant phyllodes tumor that displayed focal MNF116 CK7 and 34 beta E12 expression within the stromal cells. A study from Johns Hopkins Hospital found that malignant phyllodes tumors also expressed P63 and P40 and concluded that immunoreactivity with these markers alone is not diagnostic of metaplastic carcinoma, especially on limited material such as core needle biopsy. Here's an illustration of a malignant phyllodes tumor expressing P63 in the nuclei of the malignant stromal cells. Let's turn now to surgical margins. The traditional approach to treatment of breast phyllodes tumors has been complete surgical excision to negative margins. But today, do all breast phyllodes tumors have to be widely excised? And if so, what is an optimal surgical margin width? This table lists some studies that have been conducted in relation to the margin widths of breast phyllodes tumor excisions ranging from 1 mm to 10 mm and more, finding variable correlation with local recurrences. Our consensus paper, published a few years ago, agreed that tumor on ink or less than 1 mm wide can be regarded as a positive margin. There has been accumulating evidence, however, that benign phyllodes tumors need not be widely excised, the most recent publication in 2020. However, wide excision is still recommended for recurrent and malignant, and most would agree borderline as well, tumors. Finally, I'll just talk about molecular genetics. This was a paper published in 2014 in which we found highly recurrent MET12 somatic mutations in breast fibroadenomas, and was followed very quickly by a paper reporting on MET12 mutations in phyllodes tumors as well. The following year, we described the genomic landscapes of breast fibroepithelial tumors that led to this genomic map, in which MET12 mutations appeared to be truncal in nature, found in the entire spectrum of fibroepithelial lesions from fibroadenoma to all grades of phyllodes tumors. A similar observation was noted for RARA, whereas for this group of genes, they confined themselves to phyllodes tumors. Cancer driver mutations in these genes were seen only in the borderline and malignant grades of phyllodes tumors. This led us to propose a model for the genomic progression of fibroepithelial tumors that starts with MET12 or RARA mutations triggering the formation of the fibroadenoma, with abnormalities in these genes spurring the formation of benign phyllodes tumors, and acquisition of cancer driver mutations pushing the grade into borderline and malignant. So just a note that this event is likely to be extremely rare when we look at the numerous fibroadenomas that we encounter on a daily basis versus the much rarer benign phyllodes tumors. So just a few words about MET12 mutations. This is a gene that is located on the X chromosome. Frequent MET12 exon 2 somatic mutations have been only previously described in the uterine leiomyoma, and the MET12 mutation spectrum observed in fibroadenomas was nearly identical to that of uterine leiomyomas in both exon location and variant codon preference, and it was therefore possible that the MET12 exon 2 mutations in fibroadenomas and phyllodes tumors could be linked with hormonal expression. This is an article reviewing the evolutionary origin of borderline and malignant phyllodes tumors, and apart from the MET12 dependent pathway, there is a MET12 independent process which goes through abnormalities in TERT, EGFR, and other oncogenes. What's the clinical relevance? Firstly, a genomics-based classification of breast fibroepithelial lesions is possible, enhancing diagnostic accuracy, for instance, differentiating the fibroadenoma from phyllodes tumor, the phyllodes tumor from other spindle cell tumors, malignant phyllodes tumors from metaplastic spindle cell carcinoma. Secondly, the discovery of candidate therapeutic targets can open avenues for treatment of borderline and malignant phyllodes tumors. Thirdly, MET12 mutations are possibly prognostic, correlating with improved disease-free survival. And finally, MET12 and RARA mutations linked to hormone receptor signaling can open opportunities for future hormonal treatment. To summarize, I've talked about the pathology of fibroadenomas and phyllodes tumors, focusing on young patients, core biopsy, interpretation, grading, diagnostic challenges. We've talked about surgical margins and the emerging role of molecular genetics in terms of understanding the pathogenesis of these lesions as well as potential clinical applications. I'd like to thank you for your kind attention.
Thank you, Professor. And we have some questions from the audience. The first question is about reporting phyllodes tumor in the biopsy tissue. In reporting a biopsy tissue of phyllodes tumor with only benign features seen, would you commit to reporting as is benign on biopsy, or would the size of the tumor influence your decision in case we are missing a borderline or malignant tumor?
That's a very good question. And on core biopsy, it is really a sampling of the tumor. And the grade of the phylloides tumor that you may provide is a provisional one. And it really depends on the final excision before you give the conclusive grading of the tumor. So if I see a core biopsy and there are features of phylloides, and there are no areas that I would be worried about malignancy, I would make a comment to say that, you know, the features present suggest that it could be a benign phylloides tumor. However, you know, it really depends on the excision specimen, and the final grading has to await that.
Okay, thank you, Professor. And another question is, with overlapping histologic feature between benign, borderline, and malignant phylloides tumor, which feature do you feel to bear the greatest weight in deciding the grade of phylloides tumor?
Yeah, so that's a tough question, and I think that's one of the challenges with grading phylloides tumors, because we have to look at multiple parameters, and you know, different pathologists, you know, like use different parameters differently. So some may feel that stromal overgrowth is a much more important feature for them to lean towards a malignant grade than perhaps, you know, cytologic atypia of the stromal cells. So in terms of evaluating these parameters, the recommendation is that if you want to make a diagnosis of a malignant phylloides tumor, all these parameters should swing towards, you know, the malignant side of the spectrum. But there will be cases in which some of the parameters are really sort of like very bizarre and severe. So, you know, I've had cases in which the stromal cytologic atypia and the mitotic count have been very high. And there is unfortunately no stromal overgrowth, but there is, you know, like permeative borders. And how would one grade this just because there is no stromal overgrowth? Do you then relegate it to a borderline category? So I think for these cases, it's important to express the difficulty in the report. And, you know, some of these cases can be treated as if it is a malignant tumor. And you could comment that, you know, it really sort of like veers towards malignancy, but it may not have fulfilled all the features. In general, you know, the clinicians may treat these tumors as malignant for the purposes of management. So the short answer to the question is that there is no universal agreement on which parameter is more important. And that's why we worked around it by developing that nomogram, which is based on the weighted importance of the different parameters. And we found that atypia, mitotic activity, stromal overgrowth, and the status of the surgical margins seemed to be most relevant in predicting the biological behavior. But of course, you know, this nomogram is not perfect, and probably needs to be refined as more information about the behavior of phylloides tumors becomes available.
Thank you. And I have some question. In young patient, do you have any practical point for distinguish between juvenile fibroadenoma with feature of phylloides tumor and benign phylloides tumor?
Yeah, so in young patients, the stroma tends to be a bit more cellular, and mitotic count can be also a little bit active. And there would be very few instances of phylloides tumors in the young, to be, from my experience, looking at some of the cases in the pediatric population. So there can be sometimes phylloidal type fronts, and usually in our review of the pediatric fibroadenomas, these phylloidal fronts tend to be not very well developed. They tend to be smaller, and therefore we have a rather high threshold for calling anything phylloidous tumors, because in the young, if you call something a phylloidous tumor, usually, the clinicians may want to ensure that there is complete excision, and then, there might be some, cosmetic issues as well. So I would hesitate calling a fibroepithelial tumor in the young with a cellular stroma and a few sort of like poorly defined fronts as a phylloidous tumor. I would, sort of like have a higher threshold. And, most of these cases would turn out to be either cellular fibroadenomas or juvenile fibroadenomas.
Thank you, Professor. And the last question is about malignant phylloid tumor. In the case of malignant phylloid tumor with osteosarcoma, should the sarcomatous component be mentioned in the final report?
So heterologous elements in malignant phylloidous tumors are not frequent. And there have been some studies that have shown that the presence of a malignant heterologous element, sort of like affects or impacts the behavior and the prognosis. Our own work on our malignant phylloidous tumors found that if there was a heterologous element in larger phylloidous tumors, they were more likely to metastasize. So I think that it is important to mention the heterologous element that is present in the report. Whether or not you want to put it in the diagnostic line, I think that's really dependent on individual pathologists, but in the body of the histopathology report, it is important that the type of heterologous element be expressed. And the reason for saying so is that liposarcoma used to be a heterologous element that would define malignancy in a phylloidous tumor, but the latest WHO classification has now taken it out from that diagnostic category. So I think it's important that, one sort of like states and stipulates the type of malignant heterologous element that is present within the malignant phylloidous tumor.
Okay. Thank you so much, Professor, for giving us a valuable speaker lecture. And now may I invite Dr. Somboon Kilawat, the President of IAP, for thanks to our speaker.
Okay. Yes. Thank you very much, Professor Quay Hun. It was a very excellent lecture, and the audience, I can feel that they are very interested in the topics, and a lot of questions coming to you. I hope that all the audience will get benefit from this talk and can apply the knowledge you have gained today for your practice, everyday practice. Yes, on behalf of the IAP Thailand, I would like to express my gratitude to Professor Tan Quay Hun for devoting your time, especially today is Saturday, which should be time for family. Yeah, we are very appreciate your contribution. Also, for the audience, I would like to thank you, all the audience, for joining today's activities. Unfortunately, we cannot meet personally due to the pandemic, which I hope it will be gone soon, and I hope to see all of you in the future in physically. Yes. The last thing I would like to invite you all of you to participate in our IAP annual meeting this year. We will have the meeting during 6 to 8 October. Yes, this is our tentative speakers. Okay, not tentative, already confirmed. Okay, so yes, thank you very much, and have a great weekend and stay safe. Bye bye. Thank
Bye.
you, Professor.
Thank you. Bye.
Thank you so much. And on behalf of IAP organization, thank you all participants to join us. It has been pleasure to host this event and see you again next time in IAP Thailand annual meeting in October. สวัสดีค่ะ